Our next speaker is Dr. Bunja Rungruang. Dr. Rungruang completed her undergraduate degree at Emory University. She was a classmate of one of our fellow presenters and favorite society members, Dr. Champa Woodham. Her medical degree was completed at the University of Alabama in Birmingham. She then completed both her residency and fellowship in gynecologic oncology at McGee Women's in Pittsburgh before joining the faculty at the Medical College of Georgia at Augusta University. She currently serves as the Gynecologic Oncology Division Director. She started the first and only Gynecologic Oncology Fellowship in Georgia in 2017 and serves as Fellowship Program Director and is the incoming co-director of the SGO Program Directors Network. She lives in Augusta with her husband, 2 children, and 2 whippet dogs. Dr. Rungruang is a member of the GOGS Annual Meeting Planning Committee and was instrumental in coordinating our simulation lab activities that we unfortunately so desperately miss this year, but look forward to seeing next year. Please join me in welcoming Dr. Rungruang as she presents her lecture, "The Print is Just Too Small," a summary of the 2019 ASCCP guidelines. Dr. Rungruang.
Good morning. I would like to thank Dr. Kotke, Dr. Woodham, and the program committee for allowing me to speak today. I have no financial disclosures. This presentation utilizes content from the ACOG CREOG curriculum resources from the ASCCP Risk-Based Management Consensus Guidelines Toolkit. Today, our objectives are to review the current cervical cancer screening guidelines, discuss the changes from the 2012 to the 2019 ASCCP Risk-Based Management Consensus Guidelines, describe the management of rare cytology results, and describe the management of special populations. We are all aware of these, but just a quick refresher on the current cervical screening guidelines. This is from an ACOG practice advisory in April of this year and is in line with the U.S. Preventative Task Force recommendations. Throughout this talk, when I reference routine screening, this is what I am referring to, whereas the term surveillance is used to describe the follow-up time after an abnormal result until the patient meets criteria to return to routine screening. There are 4 points to remember with this. First, these recommendations apply to individuals with a cervix who do not have any signs or symptoms of cervical cancer, regardless of their sexual history or HPV vaccination status. These recommendations do not apply to individuals who are at high risk of the disease, such as those who have previously received a diagnosis of a high-grade precancerous cervical lesion, and also do not apply to individuals with in utero exposure to DES or those who have a compromised immune system. Second, primary high-risk HPV testing is FDA approved for use starting at age 25, and ACOG, ASCCP, and SGO advise that primary high-risk testing every 5 years can be considered as an alternative to cytology-only screening in average-risk patients aged 25 to 29 years. Third, adequate negative prior screening test results are defined as 3 consecutive negative cytology results, 2 consecutive negative co-testing results, or 2 consecutive negative high-risk HPV test results within 10 years before stopping screening, with the most recent test occurring within the recommended screening interval for the test used. And fourth, for patients who undergo hysterectomy with removal of the cervix, ACOG, ASCCP, and SGO advise no screening in individuals who do not have a history of high-grade cervical precancerous lesions or cervical cancer. So, now that we have reviewed the screening guidelines, let's talk about how to manage abnormal results. Back in the good old days, we would have opened the ASCCP management algorithms that we probably all had saved on our computers, found the appropriate flowchart, and followed the directions. But now, the print is just too small for these 2019 risk tables for management guidelines, and there's so many of them. So let's start off with an introduction to the 2019 risk-based management guidelines. Why were these developed? The 2012 guidelines were complex, and now high-risk HPV testing is readily available. The data set used to develop the guidelines is the Kaiser Permanente Northern California Data, or KPNC, which is the largest and longest real clinical experience with HPV-based screening in the world. It includes over 1.5 million women with routine co-testing from 2003 to 2017 and HPV genotyping for about 19,000 patients. The KPNC is a generally well-screened population with cervical cancer rates lower than the national average, so the ASCCP also compared risks and risk-based management to that of 4 other large cohorts or trials, including the less well-screened New Mexico population, and found 5-year risks to be similar. This comparison was limited to cytology-based results, except for ASCC's HPV positive or negative, so this demonstrates that this data set is generalizable to a wide population. Finally, the benefit of the updated guidelines is that this provides risk-based evidence for most of the common decision points that occur in screening, and the long length of follow-up allows use of past history for more personalized management. Now, as we move on to the guidelines and the risk management tables, there are 2 fundamental concepts to keep in mind. Number 1, the longer an HPV infection has been present, the higher the risk of precancer and cancer. And number 2, management is based on risk, not results. Looking at fundamental concept number 1, the longer an HPV infection has been present, the higher the risk of precancer and cancer. First, time matters. Studies show that most HPV infections become undetectable in 1 to 3 years, and those that persist cause CIN3+ over time. Second, the type matters. HPV-16 is the most dangerous type and carries a higher risk of developing CIN3+, followed by HPV-18. And finally, new from the prior guidelines, other patient factors do not matter if you know the HPV status. For example, colposcopy is always indicated following 2 consecutive positive HPV tests. This concept is well illustrated in this figure. On the left, it shows that the majority of HPV infections will clear in 1 to 3 years. However, looking at the small percentage that persist, moving to the figure on the right, if still present at 5 years, the rate of CIN3+ precancerous or cancerous lesions increases markedly. Based on this concept, the 2019 guidelines were changed to prefer HPV-based testing for follow-up of abnormal results. Surveillance with cytology alone is acceptable only if testing with HPV or co-testing is not feasible. Cytology is less sensitive than HPV testing for detection of precancer and is therefore recommended more often. In the new risk-based management guidelines, cytology is recommended at 6-month intervals for surveillance when HPV testing or co-testing is recommended annually, and cytology is recommended annually when 3-year intervals are recommended for HPV testing or co-testing. Going back to our fundamental concepts, let's discuss the second one now. Looking at fundamental concept number 2, management is based on risk, not results. Recommendations of colposcopy, treatment, or surveillance will be based on a patient's risk of CIN3+. This is determined by a combination of the patient's current results and past history, including unknown history. The same current results may yield different management recommendations depending on the history of recent past test results. This figure illustrates the impact of past history. Given that the threshold for colposcopy is an immediate risk of CIN3+ of 4%, having a co-test negative result prior to HPV positive ASCCS, which is the blue bar, results in surveillance with a co-test at 1 year, as compared to colposcopy for those with an unknown history of HPV or HPV positive normal cytology result in the next 2 yellow bars. Based on this concept, the 2019 guidelines were changed to reflect that care is now based on the risk of developing CIN3+, rather than a specific combination of tests. Now that we understand the 2 fundamental concepts behind the 2019 guideline changes, the next topic to grasp is that patients are now stratified into risk levels. This figure from the management guidelines demonstrates how a patient is evaluated. First, for a given current result and history combination, the immediate CIN3+ risk is examined. If the risk is 4% or greater, immediate management via colposcopy or treatment is indicated. If the immediate risk is less than 4%, the 5-year CIN3 plus risk is examined to determine surveillance based on a specific clinical action threshold, whether patient should return at 1, 3, or 5 years. Translating these levels into management, the new guidelines manage high-risk patients more aggressively and triage them to treatment. The new guidelines manage medium-risk patients the same as the 2012 guidelines. And low-risk patients are managed less aggressively to avoid unnecessary testing in this group. We all need to get used to these guidelines. These will be enduring because they are based on clinical action thresholds rather than specific test combinations. So, let's break down each of these risk groups further. Very high-risk patients may proceed directly to an excisional procedure without colposcopy or biopsy. Let's review the expedited treatment thresholds, which means excisional treatment without confirmatory colposcopic biopsy. Based on the immediate risk of CIN3+, if risk is less than 25%, then colposcopy and biopsy is preferred. If immediate risk of CIN3+ is 25 to 59%, then either immediate excisional treatment or treatment after colposcopy with biopsy confirmation are acceptable. In the highest risk patients with immediate risk of CIN3+ at 60% or more, immediate excisional treatment is preferred, but treatment after colposcopy with biopsy confirmation is still acceptable. These guidelines are of course not recommended for patients less than 25 years of age or pregnant women, similar to the previous guidelines. A change in the 2019 guidelines is expedited treatment is preferred for non-pregnant patients more than 25 years old at very high risk, which is for two very specific combinations of test results. These two very high-risk patient groups have an immediate CIN3+ risk of 60% or greater and should proceed directly to a diagnostic excisional procedure. HPV 16 plus HSIL in any patient, regardless of past history. In this group, HSIL with HPV 16 positive has an immediate CIN3 plus risk of 60%, a CIN2 plus risk of 77%, and an immediate cancer risk of 8.1%. The second group is HPV positive HSIL, regardless of genotype, who were underscreened, defined as no screening in more than 5 years. This group has an immediate CIN3 plus risk of 64% and CIN2 plus risk of 82%. Let's move on to the next group, the medium risk patient management. In this group, the management options are the same as the previous guidelines, and either expedited excisional biopsy or colposcopy with biopsy are acceptable. Again, going back to the expedited treatment thresholds, which means excisional treatment without confirmatory colposcopic biopsy, this medium risk patient category includes an immediate risk of CIN3 plus at 25 to 59%. Then, either immediate excisional treatment or treatment after colposcopy with biopsy confirmation are acceptable. Expedited treatment is an option for all high-risk results in the medium-risk patient. Following shared decision-making, excisional treatment without confirmatory colposcopy with biopsy is an option for non-pregnant patients over the age of 25 with HPV-negative HSIL, which has a 25% immediate risk of CIN3+, HPV-positive ASCH, which has a 26% immediate risk, HPV-positive AGC, all categories, which has a 26% immediate risk, and HPV-positive HSIL, with regular screening over the last 5 years, which has the highest immediate risk of CIN3+ in this group at 49%. Let's move to the next group, the lower risk results in the medium risk management group. In this group, management is still required when the immediate risk of CIN3+ exceeds the clinical action threshold for colposcopy at 4%, based on current results and past history. However, because the immediate risk of CIN3+ is less than 25% in this group, colposcopy is recommended rather than any type of excisional procedure. Colposcopy is preferred for lower risk results in the medium risk patient. Common cytology and HPV results that meet the criteria for this category, which is Greater than 4% but less than 25% immediate risk of CIN3+ include HPV positive ASCCP, which has an immediate risk of CIN3+ of 4.5%, and HPV positive LSIL, which has an immediate risk of CIN3+ of 4.3%. A change in the 2019 guidelines is that prior past history changes the risk category. This table illustrates this well and is taken from the ACOG ASCCP toolkit. For example, with a prior negative HPV test result, in the cases of HPV positive LSIL and HPV positive ASCCP, the immediate risk of CIN3+ changes from being above the 4% threshold for colposcopy in the column on the right to falling below the colposcopy threshold, as seen in the middle column, at 2%, such that colposcopy would no longer be recommended with a prior HPV negative test result, and the patient would be triaged to follow up in 1 year as compared to a colposcopy. One exception to the last slide for HPV positive ASCCP and LSIL is reflective of the change in the 2019 guidelines that current HPV type changes the risk category, particularly HPV 16 and 18. This table illustrates this well and is also taken from the ACOG ASCCP toolkit. In the last slide, we saw that with a prior HPV negative result, the risk for HPV positive ASCCP or LSIL falls below the colposcopy threshold. However, this table demonstrates that type-specific testing showing HPV 16 positive increases the risk above the colposcopy threshold, regardless of prior history, at 5.3 and 6.7% respectively. Other exceptions to the colposcopy threshold. Colposcopy is recommended for the following: all ASCH patients, regardless of HPV status. Although HPV negative and positive ASCH have very different immediate risk of CIN3+ rates at 3.4 versus 26%, they have similar immediate cancer risks of 0.69 and 0.92% respectively. Colposcopy is also recommended for all HPV 18 positive patients, even if normal cytology and prior negative HPV, due to a higher risk of cancer compared with other results, with a 0.2% immediate cancer risk and a 0.56% risk of cancer at 5 years. Similarly, all HPV 16 positive, except for HSIL, which remember goes straight to LEAP, regardless of normal cytology and prior negative HPV status, goes to colposcopy as well due to the higher risk of cancer. And finally, colposcopy is recommended after any HPV positive result 2 times in a row or 2 consecutive unsatisfactory screening results on cytology. Now let's move on to the low-risk patient management. These are patients where the immediate risk of CIN3+ is less than 4%. So they would not qualify for colposcopy. So instead of using the immediate risk of CIN3+ to triage these low-risk patients, instead we use the 5-year CIN3+ risk to determine surveillance interval based on a specific clinical action threshold as to whether the patient should return at 1, 3, or 5 years. This allows low-risk patients to be managed less aggressively in order to avoid unnecessary testing in this group. Surveillance is defined as follow-up testing at a shorter interval than that currently recommended for routine screening with either HPV primary testing or co-testing at 5 years. Surveillance is recommended for patients whose immediate risk of CIN3+, based on current results in screening history, is higher than the risk of the general population, but lower than the risk at which colposcopy is recommended, such that surveillance intervals are then based on the 5-year risk of CIN3+, rather than the low immediate risk of CIN3+. This figure is from the ACOG ASCCP toolkit and presents a summary of the 3 surveillance intervals, which again is based on the 5-year risk of CIN3+. In the low-risk patient management group, let's start with the group that gets triaged to a surveillance interval of a 1-year return. These are patients where, based on past history and current results, the immediate CIN3+ risk is less than 4% or the colposcopy threshold, but the 5-year risk of CIN3+ is 0.55% or more, so close follow-up is warranted, with repeat testing in 1 year with HPV-based testing with either co-testing or primary HPV testing. Common cytology and HPV results that meet the criteria for a 1-year return surveillance visit with HPV-based testing include HPV positive normal cytology, which has a 2.1% risk of CIN3+ immediately, and HPV negative LSIL, which has a 1% immediate risk of CIN3+. Going back to the low-risk patient management group, let's move on to the group that gets triaged to a surveillance interval of a 3-year return. The risk in this group should be similar to that of a negative cytology-only PAP in a screening population. Based on risk modeling of the 5-year CIN3+ risk of a NILM result, patients that meet the 3-year return surveillance interval have a 0.15 to 0.54% risk of CIN3+ at 5 years, which corresponds to an HPV positive rate of about 9% among normal cytology results. Common cytology and HPV results that meet the criteria for a 3-year return surveillance visit with HPV-based testing include HPV negative ASCCP screening result, which has a 0.40% risk of CIN3+ at 5 years, HPV negative LSIL, followed by an HPV negative normal cytology co-test, which has a 0.4% risk of CIN3+ at 5 years, LSIL co-test, followed by an immediate colposcopy with CIN1, then HPV negative NILM follow-up testing, which has a 0.42% risk of CIN3+ at 5 years, and CIN2 to 3 that gets treated with a LEAP, followed by a 3 negative co-test, and this has a 0.35% risk of CIN3+ at 5 years. Going back to the low-risk patient management group again, let's move on to the final group, which gets triaged to a surveillance interval of a 5-year return. Using the principle of equal management for equal risk, the clinical action threshold corresponds to the 5-year CIN3+ risk after a negative HPV-based screening with either HPV testing or HPV co-testing in the general population for whom national guidelines recommend a 5-year return. This corresponds to a 5-year CIN3+ risk of less than 0.15% based on past history and current test results. Note that cytology alone is never recommended for a 5-year return. Remember that in the new 2019 guidelines, past history is very important and can lower risk. 2 particular scenarios include: first, negative screening HPV testing lowers risk. Negative screening HPV test or co-test within the past 5 years reduces the risk of minimally abnormal results. For example, negative HPV or co-test followed by HPV positive ASCCP or LSIL returns in 1 year with no colposcopy. This is because the prior negative HPV testing lowers the risk from 4% to 2%, so below the colposcopy threshold. Second, negative colposcopy lowers risk. Colposcopy that excludes a high-grade precancer by confirming a diagnosis of less than CIN2 reduces the risk of subsequent minimally abnormal results. For example, colposcopy confirming the absence of high-grade disease followed by HPV positive ASCCP or LSIL returns in 1 year with no colposcopy. Again, this is because the prior negative colposcopy result lowers the risk from the colposcopy threshold of 4% down to 2%. Next, I want to shift gears over to specific scenarios. I'm a flowchart kind of person, so it really killed me when they took all the algorithms away. So I've tried to recreate some. Keep in mind you still need to calculate risk via the tables or app, but this gives you a rough idea of how the guidelines translate over to real life now. So let's take an LSIL PAP. If you remember from our red, yellow, and green stratified groups, HPV 16 positive HSIL falls into the highest risk category with an immediate CIN3+ risk of over 77% and an immediate excisional procedure without colposcopy is preferred. Similarly, any HPV positive HSIL without previous routine screening is also high risk with an immediate CIN3+ risk of over 60% and also gets an immediate excisional procedure. Remember that past history matters, so HPV positive HSIL with a previous normal routine screen is now medium risk with an immediate risk of CIN3+ at 49% and either an immediate excisional procedure or colposcopy with biopsy would be acceptable. And similarly, HPV negative HSIL, the immediate risk for that is for CIN3 plus is 25% and falls also into the medium risk category, with either an immediate excisional procedure or colposcopy with biopsy being acceptable. So in this patient, you proceed with an excisional procedure. In the new guidelines, margin status does not matter for surveillance. Only 56% of persistent or recurrent precancer was predicted by positive margin status versus 91% with HPV-based testing. So based on this, the patient should undergo initial intensive surveillance with HPV-based testing at 6 months, then at 1 year, and then again at 1 year. If all of these 3 HPV-based tests are negative, then the patient's 5-year risk of CIN3 plus now falls below the threshold of 1-year surveillance to now 0.35%, and the patient can go to a 3-year surveillance with HPV-based testing. However, given their past history, they will need to stay at 3-year screening intervals because they will not meet the criteria for 5-year HPV testing ever. The KPNC data used for the 2019 guidelines suggests that the 5-year CIN3 plus risk remains above the 0.15% threshold for return to routine 5-year HPV-based testing, and this risk seems to persist for at least 25 years. So assuming no further abnormalities, this patient would need to continue with HPV-based testing at 3-year intervals for at least 25 years from when the treatment was recommended, even if this is beyond age 65. So now let's take the same HSIL PAP, but in this scenario, the patient only falls into the medium risk category with either HPV positive HSIL with a previous normal routine screening with an immediate risk of CIN3 plus at 49%, or HPV negative HSIL with an immediate risk of CIN3 plus of 25%. Remember that in this medium risk category, either an immediate excisional procedure or colposcopy with biopsy are acceptable management strategies. So using shared decision making, the patient opts for colposcopy with biopsy. Colpo was adequate and ECC was negative, and biopsy confirmed CIN2. At this point, excisional treatment is preferred, but this patient is very concerned about future pregnancy. Although several studies have concluded that excision is associated with an increased risk of preterm birth, especially as excision depth increases, others have found no such association after adjusting for confounding factors. With shared decision making, the patient opts for observation, which is acceptable provided that her colposcopy was adequate and the ECC was negative. Observation is an acceptable option because CIN2 has an appreciable regression rate. In a meta-analysis, 50% regressed, 32% persisted, and 18% progressed to CIN3+. Most regressions occurred within the first 12 months of observation. So, based on this timing, initial intensive observation includes both colposcopy and HPV-based testing every 6 months for the first 12 months. Then, after 2 consecutive evaluations with less than CIN2 and less than ASCH, then the 5-year risk of CIN3+ falls into the range of 1-year surveillance with HPV-based testing. Then, after 3 negative surveillance HPV-based tests, then the 5-year risk of CIN3+ falls into the range of a 3-year surveillance moving forward, and this will need to occur for a total of 25 years from the CIN2 histology. So now let's take the same HSIL PAP here on the left side of the screen in the red box, where the patient falls into the medium risk category with either HPV positive HSIL with a previous normal routine screen or HPV negative HSIL. Again, in this medium risk category, either an immediate excisional procedure or colposcopy with biopsy are acceptable management strategies. Using shared decision making, the patient opts for colposcopy with biopsy. The colpo was adequate, the ECC was negative, and biopsy confirmed CIN1 this time. At this point, either an immediate excisional treatment or observation with colposcopy and HPV testing at 1 year are acceptable options. Now, let's take an ASCH PAP instead in this red box. This also falls into the medium risk category. The patient opts for colposcopy. The colposcopy is adequate, ECC is negative, and biopsy confirms CIN1. At this point, however, unlike the H-cell pap scenario on the left, observation is recommended now, with colposcopy and HPV-based testing at 1 year. The rationale for this difference between these two different medium risk scenarios showing CIN1 is that the risk of CIN3 plus at 1 year is highest following CIN1 that is preceded by H-cell versus CIN1 that is preceded by ASCH at 3.9% versus 1.4% respectively. So now let's take the same H-cell or ASCH pap, and the patient opts for observation with colposcopy and biopsy, which confirms CIN1. Observation is recommended with colposcopy and HPV-based testing at 1 year, at which time a second consecutive biopsy shows CIN1. At this point, the preferred management is continued observation, with the rationale being that the regression rates for CIN1 are high, especially in younger patients, regardless of whether CIN1 is found on ECC or biopsy. A study of 126 women undergoing LEAP for CIN1 on 2 consecutive visits for 2 years found that 87% had CIN1 or negative pathology, whereas only 13% had CIN2+. Alternatively here, treatment with excisional procedure does remain an option for persistent CIN1, but this is only after a discussion regarding shared decision making. There are 2 important points to remember about long-term follow-up recommendations. All abnormalities require an initial period of intensive surveillance followed by a longer period of surveillance at 3-year intervals. Return to routine 5-year co-testing is currently recommended only for 2 scenarios. These include, number 1, HPV negative ASCUS that is followed by a negative HPV or co-test. Or number 2 would be a minimally abnormal result followed by colposcopy with biopsy confirming less than CIN2, followed by 3 negative HPV tests or co-tests. Any and all other scenarios require HPV-based testing every 3 years until either the age of 65 or until 25 years from their H-cell treatment. Second, the length of intensive surveillance depends on the abnormality. HPV testing or co-testing are more sensitive than cytology alone in detecting CIN2+ in both the post-colposcopy and the post-treatment settings. For example, CIN1 or normal biopsy at colposcopy is followed by intensive surveillance with just 1 negative HPV-based pap test before returning to 3-year surveillance intervals. However, treatment of higher grade disease with CIN2 or 3 must be followed by 3 negative HPV-based tests before the 5-year risk of CIN3+ falls below the threshold to allow for 3-year surveillance intervals. Now let's move on to some of the rare cytology results, starting with atypical glandular cells, or AGC, all subtypes in non-pregnant patients. This result requires immediate management with colposcopy and ECC, regardless of any HPV result or any past history. In addition, in patients over the age of 35 or in those under 35 with risk factors, which would include abnormal uterine bleeding, chronic anovulation, or obesity, an endometrial biopsy is also indicated. For results of AGC favor neoplasia or AIS cytology, an excisional procedure is recommended regardless of the colposcopy findings because these carry a CIN3+ risk of 55%. If the excisional results are less than CIN2, which is there on the left side, then surveillance includes HPV co-testing at 1 and 2 years, and if both are negative, then you can continue with HPV-based co-testing every 3 years. The caveat to this is if any surveillance test is abnormal at any time, then colposcopy is recommended. For CIN2+ or worse on the right side of this algorithm, then follow the guidelines as previously discussed. The rationale for this being more aggressive in this group is due to it being a poorly reproducible category. AGC is associated with AIS in 3 to 4%, with CIN2+ in 9%, and with invasive cancer in 2 to 3%. Next group is for benign cells. So for benign endometrial cells in asymptomatic premenopausal patients, no further evaluation is warranted. Conversely, for benign endometrial cells in postmenopausal women, an endometrial biopsy should be performed. And finally, for benign glandular cells in a post-hysterectomy patient, no further evaluation is necessary. And these recommendations are unchanged from the 2012 guidelines. For unsatisfactory cytology, if HPV is unknown or HPV is negative, then repeat testing with either cytology or HPV co-testing or HPV primary testing at 2 to 4 months is recommended. In patients over the age of 25 and they're HPV positive, then repeat cytology at 2 to 4 months is acceptable. However, if the HPV 16 or 18 is positive, regardless of the unsatisfactory cytology, then colposcopy is recommended in this group, again because of their higher risk of CIN3+. The rationale for this additional follow-up testing for unsatisfactory results is because the negative HPV result from a co-test with inadequate cellularity on cytology should not be interpreted as a negative primary HPV test and therefore should be repeated. The ASCCP adopted the SGO recommendations for the management of AIS, which is the next category we'll discuss, and these were published in the Green Journal last year. AIS differs from CIN 2 to 3 in that colposcopy changes may be minimal and the extent of the lesion is difficult to determine due to 10 to 15% being multifocal. Therefore, a diagnostic excisional procedure and ECC is recommended for all patients with AIS, even when hysterectomy is planned. Excisional procedures should optimally result in the removal of an intact specimen to facilitate accurate interpretation of margin status. Excision by cold knife conization is preferred unless the surgeon is able to consistently remove an intact leaf specimen of adequate length and width. And a top hat endocervical excision to do this is not acceptable. The length of the conization specimen should be at least 10 millimeters and can be increased to 18 to 20 millimeters for patients who have completed childbearing. For surgeons who are not able to consistently obtain intact excisional specimens with adequate length, referral to a gynecologic oncologist or other surgeon who specializes in the management of cervical dysplasia is preferred. Endocervical sampling with ECC above the excisional bed to evaluate for residual disease is preferred due to the frequent location of AIS within the endocervical canal and multifocal disease. There is a high risk of recurrence after excision of AIS. A meta-analysis of 1,278 patients with AIS with an average follow-up of 3 years found that even negative margins do not ensure complete resection of the disease. In this table, you can see that in the group that underwent surveillance, even with a negative margin, 2.6% recurred. In the group that underwent re-excision, 20% with negative margins had residual AIS and 2% with negative margins had invasive cancer. This is because AIS is more multifocal and associated with skip lesions, so negative margins are less reliable. This is why providing the pathologist with an intact specimen that has interpretable margins is critical, since margin status is a predictor for residual and recurrent disease, as you can see in the bottom row of the table. This figure is from the SGO recommendations for the management of AIS, adopted by ASCCP in the current 2019 guidelines. First, all AIS in all patients should be evaluated by an excisional procedure. Cold knife conization with an intact specimen of at least 10 millimeters is preferred and crucial for margin status, with a depth of 18 to 20 millimeters if done with childbearing. In the last slide, I showed you that 6% of patients with positive margins had cancer on re-excision in the large meta-analysis. Because of this and the multifocal nature of the disease, repeat excision is preferred with positive margins to rule out cancer. This is necessary to determine if a simple versus radical hysterectomy is required for treatment. However, if repeat excision is not feasible or safe, such as with a shortened cervix, then either simple or modified radical hysterectomy are acceptable in the setting of positive margins. For excisional procedures with negative margins in patients who do not desire fertility, you can then proceed with simple hysterectomy, which is the treatment of choice. since we cannot be sure that the disease has been completely resected, even with negative margins. For reproductive age patients desiring future pregnancy, however, a fertility-sparing procedure with cold knife cone and ECC followed by observation is acceptable, provided that negative margins can be achieved. If margins are positive in a patient desiring future fertility, then re-excision must be performed until margins are negative. If negative margins cannot be achieved after maximal excision attempts, then fertility-sparing management is not recommended. Surveillance after excisional treatment only applies to patients who desire fertility preservation and who have negative margins on cold knife cone. Otherwise, all other patients should undergo treatment with hysterectomy and then follow the post-hysterectomy surveillance guidelines for AIS. For initial intensive surveillance, patients get co-testing and ECC every 6 months for at least 3 years and then annually for at least 2 years. For long-term surveillance, patients with consistently negative results for 5 years may continue HPV-based screening every 3 years until hysterectomy or for at least 25 years. Once childbearing is complete, patients should undergo simple hysterectomy, but if HPV tests are consistently negative, then continued surveillance indefinitely is an acceptable alternative. Let's move on to some special populations, starting with the less than 25-year-old patients. In this group, accurate risk estimation is difficult because vaccination is rapidly changing the population level CIN3+ risk. For low-risk patients, repeat cytology alone at 1 and 2 years is recommended. At 2-year follow-up, if cytology is normal, then routine follow-up can resume. However, if low-grade cytology is still persistent at the 2-year follow-up, then colposcopy is recommended. For high-risk histology, which includes HSIL, ASCH, AGC, and AIS, colposcopy is recommended. An excisional procedure is not recommended in this population. Let's shift to pregnancy. In this patient population, pregnancy does not seem to alter the risk for or rate of progression from cervical precancer to cancer. For patients with a prior negative result and a current minor abnormality, the 2019 guidelines allow for observation with deferral of colposcopy. For patients with high-risk abnormalities based on current results and past history, if colposcopy is indicated, then it should be done by an experienced provider, given the cervical changes seen in pregnancy. Colposcopic biopsies in pregnancy seem to be safe if indicated. For CIN3 or less on colposcopy, observation is recommended because treatment of even CIN2 to 3 in pregnancy is not recommended. A diagnostic excisional procedure or repeat biopsy is only recommended if cancer is suspected based on cytology, colposcopy, or histologic biopsy. Otherwise, excision should be deferred until postpartum. However, keep in mind that approximately 11% of new mothers lose their health insurance in the postpartum period, and that number may be even higher depending on where you practice. For patients with a high-risk abnormality that would usually warrant an excisional procedure outside of pregnancy, my standard practice is to examine them each trimester without biopsies unless truly indicated, and then plan for a LEAP between week 5 to 6 postpartum, which would be before they would lose their insurance, since the post-op care will then be bundled after that. The next special group is the immunocompromised patient. This includes HIV-positive patients or those who have had a solid organ or stem cell transplant or have lupus, inflammatory bowel disease, or rheumatoid arthritis on immunosuppressive therapy. HIV guidelines are followed in this population, which includes beginning screening within 1 year of first intercourse and then screening annually for 3 years and then every 3 years with normal results. Because of the relatively high HPV prevalence before the age of 30, HPV co-testing is not recommended in patients less than 30 years of age with HIV or immunocompromised. For those aged 30 and older, HPV-based testing should be used. Colposcopy is indicated for any ASCCP HPV positive or higher result at any age. And finally, we have the post-hysterectomy group. In patients with no previous CIN2+ in the previous 25 years, or those who have completed the 25-year surveillance period from a CIN2 plus histology. Further screening is not recommended, so no PAPs in these groups after hysterectomy. For those who underwent hysterectomy for CIN2 or 3 or AIS, those patients should undergo HPV testing annually for 3 years in a row and then at 3-year intervals, and that should continue for 25 years. For patients who do qualify for screening and develop a high-grade vaginal cytology, and this would include HSIL, ASCH, or AGC, then vaginal colposcopy should be performed. Colposcopy should not be performed for low-grade vaginal cytology like LSIL. So hopefully at this point I haven't confused you more and your head's not spinning too much. I wanted to summarize by going back to this figure from our risk management guidelines. So again, remember first that for a given current result and history combination, the immediate CIN3 plus risk is examined. If the risk is 4% or greater, immediate management via colposcopy or treatment is indicated. If the immediate risk is less than 4%, so below the colposcopy threshold, then the 5-year CIN3 plus risk is examined to determine surveillance based on a specific clinical action threshold as to whether the patient should return at 1, 3, or 5 years. And again, translating these risk levels into management, the new guidelines manage high-risk patients more aggressively and triage them to treatment. They manage medium-risk patients the same as the 2012 guidelines, and low-risk patients are managed less aggressively to avoid unnecessary testing in these groups. And again, getting used to these guidelines is going to be important because of the clinical action thresholds and not based on specific test combinations. These guidelines are here to stay. So with that, I would like to thank ACOG and the CREOG Council for developing the ASCCP Risk-Based Management Consensus Guidelines Toolkit, which is available with your ACOG membership online. I highly encourage you to take a look at these, particularly at Module 2, which has problem-based learning cases and screenshots from the ASCCP app to help you get used to using these new management guidelines. Again, I want to thank Dr. Kotke, Dr. Woodham, and the program committee for allowing me to present today, and I appreciate your attention on this Saturday morning for allowing me to present as well. And with that, I'll be happy to take any questions. Thank you.
Thank you, Dr. Rungruang. I think first off, we probably should have given you 2 sessions. That was so much content. I've seen already a comment in the chat box, and I echo this. I think that I finally now feel like I might have a grasp on this, and this was a great way to present it. So thanks for all your effort. Thanks for bringing that home to us. And without further ado, we've got several questions. First, Dr. Reed, if you wouldn't mind unmuting yourself, you've got several comments and questions.
Well, yeah. When you go straight from diagnosis to surgical intervention, meaning excision of a high-grade lesion in a 26-year-old, how do you counsel her about cervical incompetence? And gosh, I actually had 3 different questions in here. What is your thought about the postmenopausal patient who may have had HPV in her history and now has vaginal atrophy? And how do you treat her differently, especially with the guidelines over 65 if you haven't had an abnormal pap smear, stopping screening at 65? Because in my experience, what I have seen is as these patients may have had normal pap smears coming up to that 65 age range, but then because of the vaginal atrophy, the HPV reactivates and they start getting more dysplasia. So how do you counsel women as they age about their needs for pap smear screening.
Okay, I'll take the cervical incompetence question first. And thank you for your questions, and thanks to everyone for their attention, and thank you to Dr. Perry as well. For the cervical incompetence, there's really not great data out there. The data is mostly retrospective, or it's case control studies. And in some of the studies, the rate of cervical incompetence can be up to about 30%, but then the numbers are much lower in some of the other studies. Some studies look at it as age-based, and so we certainly know that the risk increases if you're younger than 25, but then in that patient population, we're also screening them differently. And so in patients above 26, when I see them, it's really the depth of the excision that matters. And so we know that the risk increases as the depth of excision is greater than 15 millimeters. And so I try to factor in that information when I'm seeing them. Oftentimes when I'm seeing these patients who want a fertility sparing procedure, then I'm having to do oftentimes a second procedure on them. And if that's the case, then I usually refer those patients over for discussion with MFM about what their risk would be, because certainly if I'm having to do a second excision to preserve their fertility, then that's certainly an increased risk. If you're seeing them as the first provider for this and having that conversation about their increased risks, I certainly think that it's a worthwhile conversation to have with them. But if they meet the guidelines for an excisional procedure, as we talked about, particularly for those higher risk patients, then I think they have to weigh that risk of their CIN3 plus over time versus the slight increased risk of cervical incompetence, and seeing a high risk obstetrician when they do get pregnant and managing that risk. Versus if you've got someone that falls into that more medium risk category, and you can do some shared decision making and perhaps follow them with observation and colposcopy instead, if they're very concerned about that risk, like we talked about a little bit earlier. For your second question, this is another patient group that I get sent pretty frequently. The patients who have had they've had the prior hysterectomy, they've had HPV related disease in the past, and so they're still qualifying for cervical or at this point dysplasia screening of the vagina past the age of 65, and they're dealing with atrophy. And so in one of my last slides, looking at this patient population of the special populations, in patients that have low-grade disease that I oftentimes get referred in this patient population, I usually, if they don't have a contraindication for it, I recommend vaginal estrogen and then continued screening per their guidelines that they still are required to meet at that point. If it is a high-risk lesion, then I will do colposcopy for those patients. But again, you can consider vaginal estrogen as a treatment for the vaginal atrophy that increases their risk in that category. I oftentimes have patients that I'm having to follow past the age of 65 because of their prior history for this, and that's usually the best way to manage it.
The other question I had was, with Medicaid expansion in the state of Georgia to 6 months, does the coverage include just pregnancy-related issues, or does it include any type of treatment for cervical dysplasia as well? And I don't know the answer to that question. Does anybody?
I'm not 100% sure that I know the answer to that question either. My standard practice, like I said, is I follow them pretty closely just so I can keep track of them, so that I can get their procedure completed with either their primary GYN provider or with me before we hit the 6-week mark, just in case they lose their insurance, because I've had several lose it in the past, and then they can't afford the care, they get lost to follow up, and those are the ones that are high risk of developing cervical cancer down the road. Does anyone else know?
I guess the more important question to ask the group is, as we try to push for Medicaid expansion for postpartum care, we need to be careful about the language that's in whatever bill gets passed, and that they have complete coverage and not just maternity coverage or family planning coverage. that's just a point I wanted to put on the table.
That point, Dr. Reed, we've had several comments that Medicaid coverage is full Medicaid coverage and full benefits, but we would certainly pursue that and follow up on that. And I think that's a good point for the entirety of the membership. Dr. Rungruang, to stay on Dr. Reed's previous comment about vaginal ascus and concerns, Dr. Lancaster had a similar question, sort of a case study with a patient with hysterectomy 10 years ago, unknown reason. Now persistent ascus pap of the vagina with occasional HPV positivity. She's getting frustrated. What should he do?
Let's see, I'm looking at it here. Persistent ascus with occasional HPV positive. So I think these are tough patients because they get very frustrated from having to come in for repeated screening over time, and it's not clearing out. I have had these patients in the past where if it's been very persistent over time, I have offered them laser ablation of the vaginal cuff and have had some good results with that. But I really try to hold off on that as long as possible, and usually only if they're not meeting the lower risk guidelines that are that we currently have. I think that they give us more leeway with those patients in the current guidelines to not have to do frequent colposcopies as much as we would have with the lower grade results like we were having before. So in a patient like that, it depends on, I think, how often they're having the HPV positivity. But if they're clearing out the HPV positivity the majority of the time, and they have significant vaginal atrophy, again, consider vaginal estrogen in those patients and try to continue holding off as long as possible. But oftentimes these patients will get referred over to me because they're just getting frustrated over time and their provider is seeking another opinion.
Thank you. We have time for one more, and I'm going to circle back to Dr. Dunson Allen. Would you mind unmuting and asking your question in the context that you want to?
Yes, I'm so sorry. Thank you so much. The talk was amazing, and yes, my head was spinning, but thanks for dissecting that out for us. Wanted to just inquire, you commonly refer to treatment, quote unquote, and it seems like it was always excisional. Are other methods that we've traditionally used, such as cryo, laser, ablative techniques, appropriate in these low risk, or I guess you had medium risk patients?
That's a great question, and thank you for bringing that up. I should have included that in the talk. In the new 2019 guidelines, they do not recommend ablative procedures anymore. So they don't recommend cryo or other ablation procedures. They recommend going straight to excisional procedures.
Great, thanks.
Thank you so much, Dr. Rungruang. That was great. Thank you for being willing to answer our questions. We look forward to seeing you when we can see you in person.